Hello, my name is Christina Lebedis from Boston University Medical Center, and I will be discussing CT angiography of acute GI bleeding. I have no financial disclosures. The learning objectives of this talk are to discuss the background of GI bleeding, its clinical importance, clinical presentation, and etiologies. We're then going to dive into CTA technique and its role in the acute settings, and then cover cases and pitfalls. Acute GI bleeding is common. 2/3 of cases are seen in the upper GI tract, whereas 1/3 is seen in the lower GI tract. Approximately 80% of these cases resolve spontaneously, but can result in massive hemorrhage and death. The ligament of Treitz delineates the upper from the lower GI tract. The symptoms of upper GI bleeding include things like hematemesis and blood in the gastric contents. Lower GI bleeding manifests with symptoms such as melena and hematochezia. Clinical localization is not always accurate, as blood within the lumen of the bowel increases its peristalsis. The causes of upper GI bleeding are numerous, as listed here. Peptic ulcers dominate the list. Lower GI bleeding likewise has many different causes, with diverticulosis seen most commonly. Small bowel bleeding etiologies depend on the patient's age, with IBD seen in patients less than 40 most commonly, and in older patients, things like angiodysplasia are seen. There are many diagnostic tests for GI bleeding. They include endoscopy, tagged red blood cell scan at nuclear medicine, catheter angiography, and CT angiography. CT angiography does have a potential first-line use in lower GI bleeding, as well as in failed or non-diagnostic endoscopies in patients with upper GI bleeding. EGD is the first-line test for upper GI bleeding, as it has many therapeutic procedures that can be performed with it. It accurately localizes and characterizes the site and cause in the upper GI tract. Colonoscopy, however, is impractical and is limited for identifying a definitive source of bleeding. It requires a rapid bowel prep, which takes several hours. Device-assisted endoscopy can be performed to evaluate the small bowel. However, it is high cost. You need local expertise and patient sedation. Capsule endoscopy, while widely used and highly sensitive for detection of most small bowel diseases, is contraindicated in patients with potential for stricture. It takes about a day to get the results. There is incomplete visualization of the entire GI tract in approximately 20% of cases, and it's limited in its ability to localize disease. Tagged red blood cell scanning at nuclear medicine detects active bleeding with great sensitivity. You can image over prolonged periods of time, which will capture both arterial and venous bleeding. The disadvantages are that it is imprecise in the localization of the bleeding. It is not always available, and it is relatively time-consuming. Here in this patient with diverticular hemorrhage, we have the initial blood flow image. At 10 minutes, you can see the accumulation of radiotracer over the pelvis. It is unclear where this bleeding is occurring. It requires SPECT CT fusion to know that this is indeed within the colon and is due to colonic diverticulosis. Here's another example with radiotracer accumulation, this time in the left upper quadrant. Again, SPECT CT was needed to know that this was in the jejunum. It was from angiodysplasia. Catheter angiography detects bleeding at rates listed here. There are provocative measures which can increase its sensitivity, but they are rarely used. At angiography, extravasation, pseudoaneurysms, AV fistulas, and hyperemia can be encountered. The findings, however, are often nonspecific, and the ultimate cause is often unknown. Embolization is very successful. This is a patient with diverticular hemorrhage that went to catheter angiography and was embolized. CT has seen many advances in recent years. It is a useful tool in the ER as it defines both the site and cause of GI bleeding. The bleeding rates it can detect are listed here. The Society of Abdominal Radiology Disease Focus Panel 2019 consensus paper, which I've referenced at the bottom, issued CTA GI bleeding technique recommendations. They are as follows. No oral contrast is needed. IV contrast injection rates should be around 5 milliliters a second with a total volume of 100 to 120 milliliters injected. Triple phase CT imaging is required, including non-contrast, late arterial, and portal venous phase images. Thin axial images should be sent to PACS along with multiplanar reformats. The use of MIP and volume rendered images can be useful. Dual energy CT was also discussed in this recent paper. Virtual non-contrast images are acceptable as a replacement for a standard non-contrast sequence. There was no consensus, however, as to the number of phases acquired at dual energy. There was consensus that you can reduce the amount of IV contrast injected and that image reconstruction, specifically virtual non-contrast, low monoenergetic KEV, and iodine maps and overlays should be sent to PACS for review. Here's an example of a dual energy CT case. There's a focus of hyperattenuation within the ascending colon on this arterial phase. With the virtual non-contrast, we are confident that this is active extravasation. This was confirmed at angiography. The key finding at CTA for acute GI bleed is active extravasation of contrast, which grows and changes in morphology over time. If the patient has had recent bleeding, you will see intraluminal clot. The main benefit, as I've touched upon, of CTA in the setting of acute GI bleeding is that it localizes the bleeding site and directs therapy. CTA is becoming the initial test of choice in many emergency departments. Cases. The first example is a 58-year-old man with a history of alcohol abuse and pancreatitis with right lower lobe pneumonia. He was suffering from hypoxia, tachycardia, and a dropping hematocrit. A CTPA was ordered. Axial images through the chest demonstrate hyperattenuating foci within a fluid and air collection in the right pleural space or right lower lobe. There was worry that this was from an esophageal source. So the patient underwent CT thorax with water-soluble oral contrast, and indeed an esophageal perforation was encountered. This is an example of a duodenal ulcer. There's intraluminal contrast on the arterial phase, which was not seen. This hyperattenuating region was not seen on the non-contrast, so we know that it's injected contrast. It changes over time on the portal venous phase. And at endoscopy, they encountered deeply cratered duodenal ulcers with stigmata of recent bleeding, the punctate red foci seen along the crater walls. This is an example of a Dieulafoy lesion in the duodenum. We see active extravasation on the arterial phase. Dieulafoy lesions are dilated tortuous submucosal arteries that erode the overlying GI mucosa and cause bleeding. This is a rare example of a metastatic renal cell carcinoma which caused upper GI bleeding. This was a man who had renal cell carcinoma as well as nephrectomy 10 years ago, and he presented with melena. At EGD, he had a biopsy-proven renal cell cancer metastasis at the ampulla. The next case is a 90-year-old man, and the clinicians were concerned for infection. He underwent CTA, and we encounter an aortobiliac stent graft within the aneurysm sac. There's also air within the aneurysm sac, a very concerning finding. Along the posterior aspect of the aneurysm sac is a type 2 endoleak. When we interrogated the superior images, we saw that the third portion of the duodenum directly abuts the aneurysm sac, and there's a loss of the intervening fat plane. Along with the air within the aneurysm sac, we were worried about an aortoenteric fistula. Here in the operating room, we see the endovascular graft through a defect in the abdominal aortic wall. Angiodysplasia is a common cause of bleeding in the GI tract. It's considered a degenerative condition, with more than a quarter of patients older than 60 years old having angiodysplasia. Angiodysplasia is dilation of venules and arterioles with loss of capillary sphincter function and AV shunts. A vast majority of these lesions are asymptomatic. However, they can cause recurrent low-grade hemorrhage. Massive bleeding, luckily, is less common. At angiography and CTA, the hallmark is an early venous draining. So here, small bowel angiodysplasia is seen on sagittal, axial, and coronal images. There's a rounded focus of enhancement in the small bowel wall, consistent with an angiodysplasia. These are dilated thin-walled vessels within the GI mucosa and submucosa. They manifest on CT as focal areas, often small, of contrast enhancement in the bowel wall. Here's another case of angiodysplasia in the ascending colon, seen to best advantage on the arterial coronal phase image. More subtle at portal venous phase. And if you interrogate other images in this patient, you do see an early draining vein. This is a case of angiodysplasia causing acute hemorrhage, probably seen to best advantage on the MIP portal venous phase image in the coronal plane. When you go back to the axial image, however, we again encounter that early draining vein. This is a case of angiodysplasia causing massive GI bleed. At angiography, ectatic vessels, and early venous enhancement indicating arteriovenous shunting was encountered. Acute diverticular hemorrhages are common, as seen in this case. The patient went to angiography and successful embolization. This is an example of ischemia with bleeding. We see active extravasation in the ascending colon. At colonoscopy, there was diffuse erythema and friability of the colonic wall with a serpentine ulcer from ischemic colitis. This is an example of a GIST with acute bleeding. We see a polypoid mass in the small bowel surrounded by hemorrhage. An unusual case of lupus vasculitis causing acute GI bleeding, seen to best advantage on the MIP image in the coronal plane. This patient underwent successful embolization. After polypectomy, patients can also have GI bleeding. This patient indeed had to go to emergency embolization for this active extravasation within the colon. Rectal ulcers can likewise cause GI bleeding. Here on sagittal images, we see the same imaging features. Here's the patient's catheter angiography, also demonstrating active extravasation. The pitfalls of CTA for GI bleeding include high-density intraluminal contents, suture material, artifacts from low radiation techniques, and mucosal enhancement in collapsed loops of bowel, which may mimic extravasation. Also, hemorrhage can be intermittent. It's only detectable if the patient is actively bleeding at the time of the CTA. I wanted to show one example of a clot here within the rectum. There's hyperattenuating material, but it does not change over the phases of the CTA. Blood clot typically is around 40 to 70 Hounsfield units. So with that, I thank you for your time and attention. If you have any questions, please feel free to contact me.
Hello, and thank you for the opportunity to speak in this session. My name is Vinny Melnick from the Mallinckrodt Institute of Radiology, and it's my pleasure today to talk to you about small bowel obstruction and ischemia. I have no relevant financial disclosures. I'd like to begin my talk with a case of a patient who came through our emergency department. This is a patient with metastatic ovarian cancer resulting in peritoneal carcinomatosis. Notice that she has a thickened omentum with peritoneal nodularity, but she's also presenting with abdominal pain and vomiting, and that's because she has a small bowel obstruction clearly evident in the left mid-abdomen. Our surgical colleagues were understandably hesitant to take this patient to surgery because of her carcinomatosis, but we noted that her small bowel obstruction had inlet and outlet at the same spot, that there was this clustered appearance of the dilated bowel loops, and there was hypoenhancement with associated mesenteric edema. All of these things made us worried about a mechanical closed loop small bowel obstruction and possibly ischemia, and she was taken to surgery for management of that. When it comes to small bowel obstruction, our job as radiologists is to identify patients with ischemia and who are at risk for ischemia. Small bowel obstruction can result in ischemia either due to overdistension, that is when the intraluminal pressure exceeds that of the capillary bed, or due to closed loop obstruction, which cannot be decompressed via vomiting and nasogastric tube suctioning. Most of us are familiar with the appearance of a short segment closed loop obstruction, that is a C or U-shaped loop that is demonstrated in this example here. But remember that when a closed loop bowel obstruction involves a longer segment of small bowel, it gets this radial appearance or balloons on a string appearance, clustered loops of small bowel in an abnormal distribution, and these patients are equally at risk for ischemia. Here is a collage of 4 different patients with varying segment lengths of closed loop small bowel obstruction. Again, notice that they have this clustered appearance. Some people have described this as a bag of bowel, where they look abnormally separated from the rest of the GI tract. Look for the inlet and outlet at the same spot, at the same transition point for obstruction. Look for signs of hypoenhancement, mesenteric edema, and bowel wall thickening, complicating these as they are at increased risk for ischemia. Here's a patient who has closed loop physiology complicating his small bowel obstruction. This is a patient who's had a Billroth 2 procedure and who has a closed loop small bowel obstruction complicated by volvulus and ischemia. Notice the twisting in the central small bowel mesentery, the abrupt occlusion of the SMA, and the sort of dusky hypo-enhancing appearance of the majority of the small bowel. And unfortunately, most of this man's small bowel was ischemic in surgery, and this was an internal hernia through the transverse mesocolon, resulting in this mesenteric twisting and obstruction. Here's a more subtle case of a patient with an internal hernia causing his acute presentation to the ER. Notice the abnormal mesenteric fat touching the gallbladder, bowel loops touching the gallbladder up in the porta hepatis. This is a patient with a foramen of Winslow internal hernia causing his acute abdominal pain. This was corrected surgically. In my practice, this is the exception though. We normally don't see anatomic hernias very often. It's much more common for us to see internal hernias in patients who have postoperative anatomy like this. This is a patient who's had a Roux-en-Y gastric bypass, coming to our emergency department with abdominal pain. Notice that the small bowel appears edematous. There's an abnormal appearance to the mesenteric vessels, with vessels coursing behind the root of the small bowel mesentery. And if you look at this coronal image, there's abrupt cutoff of the SMV. All these are signs that the small bowel mesentery is abnormally oriented, it is twisted, and placing this patient at risk for mechanical small bowel obstruction, but also ischemia. When you're evaluating a patient for the possibility of an internal hernia, remember that these patients are at high risk for closed loop obstruction and ischemia. If you're looking at a patient who has not had gastric bypass, consider the possibility of an adhesion causing this appearance, unless there's a clear anatomic sign. If you are dealing with a patient who's had gastric bypass, remember that the mesenteric findings are most sensitive and include mesenteric edema and lymphadenopathy. Look at the root of the mesentery and make sure there's not abnormal bowel or vessels going behind the mesenteric vasculature. Look for a shifting bowel anastomosis. And remember that patients with internal hernias may not have dilated bowel and may not have ischemia at the time of their presentation. Here is a patient with an internal hernia. Notice the clustered loops of bowel in the right mid-abdomen. This is a gastric bypass patient. Also notice the extensive mesenteric edema and the fact that the jejunal anastomosis is located within the central abdomen. Comparison with prior studies is very helpful in these patients, and in this case, the patient on the immediate post-operative leak check had a JJ anastomosis located in the left mid-abdomen. So this shifting anastomosis, along with the high-risk anatomy, along with the mesenteric edema and clustered bowel, should all make you worried about the possibility of an internal hernia. This is a much more subtle case of a patient who has an internal hernia. This is a gastric bypass patient. Notice that there is small bowel that looks draped over the transverse colon, but more importantly, notice that the transverse colon is touching the iliac bifurcation and is located behind the small bowel mesentery. It's really not a normal anatomic relationship of the transverse colon to the small bowel mesentery, and because of this patient's high-risk anatomy, she was taken to laparoscopy the next day, and an internal hernia was confirmed. This was not obstructed or ischemic, but certainly was at risk for both. Here is a patient, another gastric bypass patient, another patient with the jejunal anastomosis in the central abdomen, which is not typical. The mesentery appears swirled. There is bowel going behind the root of the mesentery here. And on this coronal MIP image, notice that the superior mesenteric vein is markedly narrowed at the site of this twisting. So all signs that you're dealing with an internal hernia, which was confirmed operatively in this case. Here's another sign of an internal hernia that you notice by looking at the mesentery very carefully. This is a so-called mushroom sign with mesenteric vessels and bowel sort of vertically oriented, making the stalk of this mushroom. This is the site of herniation and the neck of the hernia, if you will. Also notice that the bowel appears slightly edematous. There's mesenteric edema as well, and there is engorgement of the mesenteric veins in this patient. You can see the twisting of the small bowel mesentery as you scroll through here, perhaps a little easier when you notice this rotation of the small bowel and, of course, the mushroom sign of these vertically oriented parallel loops of bowel and vessels. Having twisting of the small bowel mesentery is not limited to patients with gastric bypass and internal hernia. This is a patient who presented with a fairly obvious small bowel obstruction. Notice the dilated small bowel and an abrupt transition point in the right lower quadrant where there is twisting and rotation of the small bowel mesentery that's easier to see as you scroll through it here. This is a patient with small bowel volvulus causing obstruction, but in this case it was due to postoperative adhesions. Adhesions are the most common cause of small bowel volvulus in adults. Occasionally we also see this due to a delayed presentation of malrotation. Of course, internal hernias, as we mentioned, or other fulcrums of rotation, which I will show you momentarily. This is another patient with an adhesion causing small bowel volvulus. Notice the dilated small bowel twisting around this central point of the mesentery adjacent to this anastomosis. Easier to see as you scroll through this case here where you see this rotation of at least 360 degrees of the small bowel mesentery, complicating this patient's small bowel obstruction. They were not deemed a very good operative candidate, and so they decided to pursue endoscopic decompression, which demonstrated the twist that was then decompressed by a tube, and this follow-up CT a week later demonstrates that the volvulus and the obstruction have both resolved after conservative management with decompression. This is another patient with small bowel obstruction secondary to a twisting phenomenon in the small bowel mesentery. In this case, the cause was this mass containing fat, fat fluid level, and calcium. This is a teratoma of the small bowel mesentery causing twisting, obstruction, and mild ischemia as noted by this mesenteric edema here, and these were managed operatively. This is a more complex patient with twisting of the small bowel causing small and large bowel obstruction. In this case, the axis of rotation is the patient's jejunostomy tube, around which the colon and small bowel rotated and caused this complex obstruction due to the indwelling tube. Now, what about this patient here? This is a patient who is asymptomatic, who came into the outpatient imaging center to evaluate for a possible abdominal wall hernia, which wasn't there. But they have this twisted appearance, this rotation appearance to their small bowel mesentery. There's no small bowel dilation. There's no mesenteric edema. I'll scroll through the images here so you can see this twisting of the small bowel in the central abdomen here, close to 360 degrees of rotation. What do we do with a patient like this who has this swirling of the small bowel mesentery but no symptoms? When you see mesenteric swirling on CT, it is helpful when there's small bowel obstruction because it could be helpful predicting the need for surgery. But in the case of patients without a small bowel obstruction, you should look for secondary signs such as occluded vessels and mesenteric edema. Remember that up to a third of patients may demonstrate counterclockwise swirling of the bowel and be normal. But I would be particularly careful in patients who've had gastric bypass or other anatomic altering surgeries because they are predisposed to internal hernias, and mesenteric swirling is a very sensitive sign for that. So you really have to take that finding into the context of the patient, the secondary signs, and their operative history. Here's a patient with a small bowel obstruction, not very subtle. They have clustered bowel loops in the central abdomen. There's obstruction and swirling of the small bowel mesentery. There's bowel wall edema and mesenteric edema as well. This is a patient for whom we should be not only concerned about a closed loop small bowel obstruction involving a long segment of small bowel, but also one which has been complicated by ischemia. When it comes to ischemia complicating small bowel obstruction, the most sensitive findings are mesenteric fluid and ascites, but the more specific findings include decreased enhancement, intramural hemorrhage that may be a cause of bowel wall thickening. And keep in mind that pneumatosis may occur complicating ischemia in the setting of small bowel obstruction, but this is not very common. It's more common to see pneumatosis with arterial occlusion. Here's a patient for whom I would hope most of us would be concerned about ischemia complicating small bowel obstruction. Notice the dilated small bowel is markedly thickened, especially in the right upper quadrant and central abdomen. There's marked mesenteric edema, there's ascites, and the configuration of this bowel should also make us worried. Look at the mesenteric vessels as we scroll through this case. There's occlusion of the SMV, and the SMA gets markedly narrowed here at the site of twisting. And notice also the bowel passing behind the mesentery here in a patient with an internal hernia, complicating their postoperative anatomy of having a prior gastric bypass. Here's another case of a patient with clear ischemia complicating their internal hernia and small bowel obstruction. Again, intramural hemorrhage is the most specific sign of ischemia in the setting of small bowel obstruction. This is one such example of a patient who has this mass-like configuration of multiple bowel loops that have hemorrhage in the wall, in the lumen, and in the mesentery. Easier to see on this cine image here, where it's very hard to make out any normal appearing bowel because of this severe ischemia. So to conclude, our job as radiologists is to identify ischemia in small bowel obstruction. We do so by identifying at-risk patients, those with closed loop obstruction or closed loop anatomy, those with internal hernias or those with obvious volvulus, and then to identify ischemia itself, remembering that mesenteric fluid and ascites are the most sensitive findings, and that bowel wall hypoenhancement and hemorrhage are more specific findings. Thank you so much for your attention and this chance to talk to you virtually, and I hope that you find the meeting very valuable. Thank you.
Greetings, everyone. I'll be presenting a brief overview of imaging of the acute abdomen in pregnancy, focusing on general considerations for mostly non-obstetrical conditions, given the shortened nature of this presentation. I'll be doing a knowledge-based review focusing on safety, algorithms, areas of consensus, and controversy. I have no disclosures, but I will state that this topic became of increased interest as I had my own son several years ago, and this topic has become closer to heart. So the bottom line with maternal imaging, if there's a situation requiring imaging to make a diagnosis or confirm a diagnosis of an acute abdominal or pelvic situation in pregnancy, ideally we want to use a imaging modality that does not use ionizing radiation. Typically it starts with sonography. If we don't get an answer, and often we don't, then MR is done. If neither is doable, obtainable, or desirable, we can do other tests. If they do use ionizing radiation, we want to, of course, reduce the dose to both the fetus and the mother as low as we can get it without compromising diagnostic accuracy, so the Lauer principle. And typically, we're talking about low radiation dose CT, occasionally radiography. Time does not permit a detailed discussion of this, but there are areas of great controversy here in terms of does ionizing radiation in utero lead to an increased incidence of childhood malignancy subsequently. And although this is really very debatable and mostly theoretical as opposed to actual data, just from a public relations point of view, quite honestly, it's ideal to reduce dose or eliminate it if we can at all. And there are several papers in the literature, I've noted a few of these here, where the estimated fetal dose when the patient needed an abdomen and pelvic CT, and of course we're talking about two patients here, the mother and the fetus, and the range of estimated exposure was from about 17 to 25 milligray in these papers. More recently, the number went up a bit, and so I think we can do better. It becomes problematic later on in gestation as the anatomy gets more crowded and as the cross-sectional diameter increases. And so again, people debate this. Some say there's a risk of cancer. Very well-known CT physicist Cynthia McCullough at Mayo Clinic has been stated that the risk to the conceptus is negligible if there's a less than 50 milligray dose imparted. So there's again, areas of controversy here. And where's the actual data? Well, here's a paper published a few years ago now from Canada that showed actual data that a small cohort of pregnant women exposed to ionizing radiation for medical imaging compared to a much larger group who were not, did not have a statistically significantly increased risk of malignancy in the child. But again, if we're going to use ionizing radiation, if we have to use it, we want to use techniques such as ACER and dose modulation, etc., to, again, reduce dose, not to the point where we don't get an answer. MR at its current uses is believed to be safe. There are some concerns at higher doses. or higher field strength. Certainly wouldn't use a 7 Tesla MR in a pregnant human, but 3T, questionable. Some data suggests now it is safe, but we at our institutions would use the 1.5 Tesla or lower field strength magnets. We would get consent that's recommended by the American College of Radiology as a general policy. And we would limit sequences to those that we truly need to do. This is not an exam that we just sort of ignore. It's something that we really want to be a little more hands-on with and monitor if we can real time. And so that same group from Canada did a follow-up study published in JAMA a few years ago showing no adverse effects to the smaller group of pregnant women who had MRI during pregnancy compared with the larger group who did not. Similar kind of a cohorts series. Gadolinium, again, somewhat controversial. The evidence is more from animal models where much higher doses are used. And there have been small reports, as I've noted here, regarding women who were pregnant who received gadolinium either intentionally or unintentionally, not aware they were pregnant, and in those very small series, no definite adverse events. The ACR position currently is considered on a case-by-case basis. It's fairly rare to actually need to give it. Only in extenuating circumstances we do that. So we need to consider societal guidelines, and there are a variety of societies that have written on this topic for imaging various body parts in pregnancy, including and particularly the abdomen and pelvis, where again, if it's a CT, the fetus may have direct exposure to the ionizing radiation. So let's talk about a few entities. Appendicitis, a big one. It's the most common reason in pregnancy to have surgery other than the pregnancy itself. The clinical presentation can be variable, especially later in gestation, where the appendix can be in a much higher position than usual. And what is quite clear when you look at the literature is that if appendicitis becomes complicated in pregnancy, the risks to the fetus are substantially greater. And so we really want to make an accurate and early diagnosis. And so the negative appendectomy rate, the NAR, becomes very, very important. We really want to make that as low as possible. We want to exclude appendicitis, make the accurate diagnosis early without perforation if we can, and then make alternative diagnoses. So ultrasound is still the initial test of choice. It has major limitations, especially later in pregnancy. There are lots of problems with this. The need to have a very experienced sonographer to identify the appendix. It's often retrocecal, and then later on it gets even harder to find it. And these are often patients who come in the middle of the night, not necessarily at 1 in the afternoon. They come in at 2 in the morning. And so a variety of papers, this one on the top here from the University of Washington group showed very poor results in terms of showing a normal appendix, and even when it's abnormal, the numbers are often not very accurate with sonography alone. Some institutions, such as Mallinckrodt, WashU in St. Louis, is bypassing ultrasound for a suspected appendicitis in pregnancy. They're going directly to MRI. And so that is the next step if you have a non-diagnostic, and often, for the most part, it is for imaging suspected appendicitis in pregnancy. We use a variety of non-contrast sequences. And although the series aren't particularly huge, the reports have shown in small to relatively modest-sized series, with the exception of one multi-institutional paper that I'll present in a minute, the result much, much better than with ultrasound. So here's one paper, 127 patients, only 2 out of those 127 showed positive appendicitis on sonography, compared with MRI where 8 were positive, and the rest, the 125, were non-diagnostic. So very, very poor results. I mean, what other test are we going to tolerate looking for something, and almost always we never see it? Just doesn't make sense, doesn't fit. Another paper published a few years ago, again, a very small number of appendices seen on ultrasound versus 80% on MR, certainly much better. There have been a variety of papers from multiple institutions over the years, work from Ivan Pedroza when he was at BI Deaconess Medical Center in Boston, and others have shown in the small to medium-sized series the superiority of MRI for making or excluding appendicitis with non-contrast imaging, or as well for making alternative diagnoses. So here's that multi-institutional study I mentioned. It was a 5-year study, 709 patients, 9.3%, almost 10% were positive for appendicitis in pregnancy, and there were no differences amongst the centers. And the accuracy, positive predictive value, negative value, really quite high. The next situation we'll talk about briefly is urolithiasis. This is the most common non-obstetric maternal abdominal and pelvic condition that produces pain. It's often associated with UTI, or UTI may simulate it, or vice versa. And again, as with appendicitis, there's data that if it becomes complicated, if there's secondary infection, if this goes on for a longer period of time, that there are associations with risk to the fetus that are substantial. Ultrasound, again, is the test of choice, again, has major limitations. In this scenario, again, we rarely see ureteral calculi to begin with in non-pregnant individuals. Throw in the pregnancy situation, especially later on, gets more difficult unless it's at the UVJ or very proximal. And then the other complicating factor is, of course, this quote hydronephrosis of pregnancy that is very common, especially on the right and especially later in gestation. And so again, MRI has a role, though there are some more substantive limitations compared with MR in appendicitis. Again, non-contrast sequences. So some of the earlier series, very small numbers, showed accurate data, but there haven't, to my knowledge, been even moderately sized, more recent series showing that this is a good test. There are a variety of pitfalls. Again, one is going to see some degree of hydronephrosis, especially on the right early on, but if there's gentle tapering as we go from proximal to distal, especially on the right, if there's no perinephric edema, if it just looks like it's more of a chronic scenario as opposed to a lot of inflammation and swelling, then that would fit more with a hydropregnancy than a ureteral calculi or UTI or both. Again, we're using non-contrast multiplanar, fast T2 weighted, and other sequences. Unfortunately, it's hard to identify even relatively big calculi, regardless of where they are in the urinary tract, compared with CT. And there are potential flow artifacts that, especially at the ureteral-pelvic junction and proximal ureter, may be confused with actual calculi. And so you want to do a variety of sequences, T2-weighted, fast spin sequences. in addition to other kinds of sequences, because you may have artifacts who just do those, so steady state, free precession sequences and other sequences. And so if it really persists in all planes and all sequences, then that would fit with a true calculus as opposed to a fake out, a pitfall of flow. Again, we're looking for secondary findings, which may help us even if we have a hard time making the diagnosis of actually seeing the ureteral calculi. So if we see the swelling and the perinephric edema, and the setting is correct, and there's a normal appendix or no evidence for appendicitis, that's very helpful, even if we can't exactly identify the size, location, presence of a calculus. Again, GATA wasn't used, so there are some limitations, presumably compared with if we were to do a full-blown MRU as we might do in a non-pregnant patient. And again, there may be some challenges in terms of availability and interpretation. It's a bit more expensive, but these challenges have become less significant over the years as more and more practices and institutions become comfortable with imaging the acute abdomen and pelvis with MR. Low radiation dose CT has a role as either a secondary or tertiary exam. We can use quite low radiation dose and still see the presence or absence of ureteral calculi accurately, and the doses can be quite low. There have been large series on this particular topic, but there have been some relatively small to moderately sized series that have shown reasonably good numbers and estimated radiation doses that are quite low. Time doesn't permit detailed discussion of other entities above and beyond trauma, which we'll spend the last few minutes on, but basically for biliary tract disorders, we would do sonography and then supplement with MR. For bowel disorders, Crohn's disease, SBO, etc., we would do maybe sonography, but certainly rely on non-contrast MR. And then certainly for imaging primary suspected pelvic abnormalities, whether the fetus or the ovaries, we would of course do ultrasound, supplement with MR as needed. So we'll spend the last few minutes talking about trauma imaging in pregnancy. Trauma is the leading non-obstetric cause of maternal death. Upwards of 6 to 7 women have some degree of trauma, and the etiologies vary from seemingly minor things to, unfortunately, non-accidental trauma, to motor vehicle collisions and other sorts of more substantial trauma. And this is really a difficult scenario because it's hard to estimate the true severity of injuries initially sometimes. The normal things that occur in pregnancy, especially later on, can mask the seriousness of injury, and there can be a lot of challenges here. So the first thing that's typically done in the trauma setting is the FAST exam. Just as with non-pregnant individuals, there's a relatively large series, all things considered, from the UC San Diego group, published a few years ago, 372 pregnant patients. Even though the numbers were small in terms of the yields, it seems like a reasonably good test, and it's done quickly, as the acronym implies, in the ER setting. It certainly has its limitations, and even more so in pregnancy, but a reasonable thing to do first. And then the question is, what do you do next? CT is certainly the test of choice for imaging any part of the pregnant woman in the trauma setting. Again, the radiation is a consideration, but it's less so in this scenario in terms of the mother has to come first, especially if there was believed to be major injuries. And we can see not only a spectrum of maternal injuries, but we can also see even uterine and fetal injuries, actual injury to the fetus, disruption of the placenta, injury to the uterus, areas of devascularization, bleeding, abruption, etc. There's no really big series, to my knowledge, looking at this. But it's sort of what has been accepted by societies and what is done. MRI, very little published on this. Every time I look at the literature, there's very little that's actually been published. We've done just a few number of patients in the more stable scenario. Of course, there are challenges in terms of bringing a trauma patient who's pregnant to the MR suite, even if you have one that's close to the ED. A couple of final comments on counseling. We need to inform patients and the referring clinicians that there's still a lot of misperception, misinformation out there. We want to use terms that patients can understand. We want to inform patients that even if we need to do, say, a CT, a single CT of the abdomen and pelvis, if it's done correctly, the risks to the fetus really are very, very minimal. We will try our best, in conclusion, to use imaging that doesn't require ionizing radiation, i.e. ultrasound or MR, often both of those, but if we have to do imaging, particularly CT, I think even in the third trimester, we can keep the dose well below 50 milligray and still get those diagnostic quality imaging examinations. Occasionally we may come across a woman who's imaged, who was pregnant, and we don't know it, we didn't test for it, and we could again want to keep the radiation dose low as a norm. And then finally, there are risks of not doing things. And so I like this quote I'll conclude with from the urological literature, quote, "Inaccurate, missed, or delayed diagnosis may represent a more significant risk to the patient, i.e. fetus and mother, than the radiation risk." And then if we do, have to use CT, we want to document the estimated radiation dose, include that in a report if necessary, get medical physics involved. So with that, I appreciate everybody's attendance, whether live in the virtual meeting or in the next few months down the road. Appreciate everybody's patience and hope everybody keeps safe. We're looking forward to the Q&A session. Here's some final additional references, some things that we've done and others have done in terms of this particular topic. And for that, again, I thank you for your attendance and for participating in this session. Thank you very much.
Hi, everyone. I'm John Pellerito. And for the next few minutes, we're going to talk about ultrasound of non-obstetrical pelvic emergencies. I have no significant conflicts of interest. Pelvic emergencies include ovarian torsion, appendicitis, and ectopic pregnancy. For this presentation, we're going to focus on ovarian torsion. And we'll also review causes of pelvic pain that have similar presentations. Let's start with this case. Here's a 36-year-old that presents with left pelvic pain. Here's a grayscale image from the transvaginal examination. We can see the uterus anteriorly with a normal endometrial canal, and we see a complex mass lying behind the uterus in the cul-de-sac with a little bit of free fluid. Here, looking at the right adnexa, we identify the right ovary. And the right ovary demonstrates numerous follicles on the grayscale image. We turn on color Doppler and we see color flow throughout the ovary. And when we sample the ovary with pulse Doppler, we can see both arterial and venous flow. Turning to the left adnexa, we now see the mass that we identified in the cul-de-sac is the left ovary with numerous follicles. The ovary is enlarged on the grayscale image, and we notice that there is internal vascularity when we turn on color Doppler. Pulse Doppler interrogation demonstrates arterial flow without venous flow. Putting it all together, we notice that on the grayscale image, we have an enlarged ovary in an unusual location in the cul-de-sac. The Doppler evaluation demonstrates that there is arterial flow without venous flow, allowing us to make a diagnosis of left ovarian torsion. Ovarian torsion represents about 3% of gynecologic emergencies, and these patients typically present with severe pelvic pain. We see it more often in premenopausal patients, as the ovary is typically enlarged and serves as the focal point for the twisting of the vascular pedicle. And we know that torsion of the normal adnexa is uncommon. Grayscale findings associated with ovarian torsion include an enlarged ovary or mass on the ovary. And here again, in this example, we see again an enlarged ovary sitting in the cul-de-sac behind the uterus with peripheral follicles, allowing us to identify the mass as the ovary with a small amount of adjacent free fluid. So we look for a cystic, complex, or solid mass to represent the abnormal ovary. And we look for the ovary in an unusual location. In addition, we want to look for a coiled or twisted vascular pedicle, which will allow us to be definitive to make the diagnosis of ovarian torsion. With Doppler, we can identify the presence or absence of flow within the ovary. In patients with complete torsion, there'll be failure to detect arterial and venous flow within the ovary. With partial torsion, we may see flow, but typically there'll be loss of venous flow, as that is the first component to go when there's twisting of the vascular pedicle. That is the low pressure system. In patients with chronic torsion, you may see peripheral vascularity around the ovary. In this study that was published by the Vanderbilt Group in the Journal of Ultrasound in Medicine, they found that the most common features associated with ovarian torsion include abdominal pain and ovarian enlargement on grayscale imaging. On the Doppler examination, they found that about 50% of patients had arterial flow and only a third had venous flow in the ovary. So there was absence of venous flow in the ovary in 2/3 of cases, which leads us to the conclusion that if you see an enlarged ovary, particularly in an unusual location, with signs concerning for torsion, even with internal blood flow, you should be suspicious for ovarian torsion. And the reason that you may see flow with a twisted vascular pedicle is that the ovary can have a dual blood supply, right? We know that the ovary gets its blood supplied from the ovarian artery, a branch of the abdominal aorta, and we can see as it comes into the ovary and gives off branches to supply the ovary. In addition, there are branches of the uterine artery that course across the broad ligament that also bring blood supply to the ovary. So you would have to have a complete twisting of both of these vessels to have absence of blood flow. So that's why it's so important to look for the whirlpool sign, which represents the twisted vascular pedicle. In this example here, you can see the swirling of vessels that lead to the enlarged edematous ovary. You can see the swirling in real time on the grayscale exam, and you can also appreciate similar findings on color Doppler. In this study, all patients had a whirlpool sign, which proved to be the most definitive sign of torsion. So on the examination, make sure you take a look for the twisted vascular pedicle or the knot. On this grayscale image here, we can see the twisted pedicle very easily adjacent to the enlarged abnormal ovary. Now, you may also see the sign on other modalities. Here we see this coronal CT scan. But in this particular case, although we see the knot, it is less specific for the diagnosis. Other causes of severe pelvic pain include endometriosis, renal colic, pelvic inflammatory disease and tubovarian abscess, as well as other inflammatory conditions including Crohn's disease and diverticulitis. Endometriosis typically presents in premenopausal women between the ages of 18 and 35 years of age. They may present with acute or chronic pelvic pain, and symptoms may be variable because they can be due to GI, GU, or thoracic involvement. The classic endometrioma is a cystic structure filled in with low-level echoes representing hemorrhage, producing the so-called chocolate cyst. Patients typically present with frequent bouts of pelvic pain associated with the menstrual cycle. Their history is so important as it informs you of the underlying diagnosis. So always ask about a history of pain associated with the menses. Also, the presentation of multiple hemorrhagic cysts, as we see on this grayscale image, is very important. Think endometriosis when you have multiple hemorrhagic cysts. And if you need to confirm the diagnosis, MRI can be diagnostic, as the T2 shading that we see in the hemorrhagic cyst can help you make the diagnosis. Another diagnosis to keep in mind in patients that present with pelvic pain is renal colic. And we can use both the transabdominal or transvaginal scan to identify the distal ureteral calculus, which can be very well seen on either modality. Here on the right, we see the stone at the level of the right ureterovesical junction, and it can be easily seen as well on the transvaginal scan. So remember, when we're doing the transvaginal scan, to consider the diagnosis, as the finding of the distal stone can be as easily seen on ultrasound as it is on CT scan when you consider the diagnosis. Pelvic inflammatory disease is another disease to keep in mind in patients that present with severe pelvic pain. With PID, we look for thickening of the tubes and adjacent structures. This may be associated with free fluid and fat stranding. With the formation of a tubo-ovarian abscess, you'll see that the tubes fill with fluid and the inflammatory material spreads across the pelvis to involve the ovary, producing a tubo-ovarian complex, making the ovary and the tubes difficult to distinguish. And with the continued spread of this inflammatory material, you can observe other complex collections. So, in summary, ultrasound is the preferred initial imaging modality for the evaluation of pelvic pain. It's very helpful for these patients because it can distinguish between gynecologic and non-gynecologic emergencies. And the addition of color and spectral Doppler can add important diagnostic information to help you work through your differential diagnosis. Thank you for your attention.